Session for day is Symposia on Bridging Discovery and Clinical Application in Regenerative Science. This session highlights cutting-edge advancements in regenerative medicine from laboratory innovation to translation into clinical practice. And to lead this prestigious session, I have the distinct honor of inviting our session chairs, Dr. Anuradha Majumdar and Dr. Manoj K. Aswar. So I request them to kindly come on the dais and officially commence the proceedings. And to recognize their eminence, I would like to take a moment to highlight the notable achievements of our esteemed chairperson. And since Dr. Anuradha Majumdar needs no introduction, as she has been the orator of our previous session, we have Dr. Manoj Kashinath Aswar, Professor of Pharmacology at Marathawad Mitra Mandalas College of Pharmacy, Pune. With over 20 years of teaching experience, he specializes in pharmacology, neuropharmacology, and preclinical research. He has published 30 papers, presented 35 conference papers, guided 18 MPharm students, and authored the textbook Pharmacology 3rd, Nirali Prakashan 2019. Recipient of the Professor P.C. Dandia Award, Dr. Aswar's work bridges academic pharmacology with translational research. He is deeply committed to mentoring students and fostering innovation, contributing significantly to the advancement of pharmacological education and research. So, with these words, I welcome our session chairs, and I request them to introduce the speakers of this symposia.
I'm honored to welcome our first speaker, Professor Buddhadeb Don, MD. He's the chairman of the Department of Internal Medicine and chief of the Division of Cardiovascular Medicine at the Kerkorian School of Medicine at the University of Nevada, Las Vegas. Prior to UNLV, Dr. Don served as the director of the Division of Cardiovascular Diseases at the University of Kansas Medical Center, where he was the Marvin Dunn Professor of Cardiology, founding director of the Cardiovascular Research Institute, and the founding director of the Midwest Stem Cell Therapy Center, and vice chairman for research in the Department of Medicine. He received his medical degree from Calcutta Medical College, India, and underwent cardiology training at the same institution. In the USA, he completed residency in medicine at the University of Missouri, Columbia, and completed fellowship in cardiology at the University of Louisville. He is a practicing clinical cardiologist and physician scientist with research interests focused primarily on heart repair with adult stem cells. He has authored over 200 articles and book chapters. He serves on editorial boards of several prominent cardiovascular journals, national scientific committees, and grant review panels. He also played a key role in a successful phase 1 clinical trial using the Wharton's jelly-derived MSCs in patients with graft versus host disease. His clinical interest includes echocardiography and atrial fibrillation. Over to you, Dr. Don.
Good morning. Thank you, Dr. Majumdar, and the co-chair, Dr. Aswar. So thank you for inviting me to this wonderful city of Chandigarh and the Punjab University, my first time here. The last time I was in Chandigarh was in 1991, a very long time ago, and I think the city has changed a lot since then. So it's really a pleasure to be here and be able to participate in this meeting. So I thought my talk time was 30 minutes, but I'll try to go over faster. And I do have, this is not a conflict, but I am a co-founder of a company that is mostly for neurological ALS treatment. It's a stem cell that I'm not going to discuss those data. So there are two types of stem cells, embryonic stem cells and adult stem cells. So these cells were described in the 90s, and can be obtained from humans. However, these are very hard to differentiate into different specific lineages, and these are truly pluripotent cells. So if even one cell is pluripotent in the injected that is going into human heart, then the patient will get a tumor. So there has not been much advance to the human clinical trials of embryonic stem cells. There has been a lot of hype, but no real advance. Adult stem cells, on the other hand, are the cells that are found in many different organs, including the skin, the hair follicles, in the GI tract, and they can be harvested from different human tissues. Almost any tissue that has been looked into has stem cells, including the cardiac myocardium. It has cardiac stem cells. So these cells can be harvested easier than embryonic stem cells, and therefore about 50 different types of adult stem cells have been tested in the lab, and some have advanced to the clinical trials. Even though we work with, my laboratory has worked with stem cells for more than 20 years, I'm not going to show basic science data for this talk because this is focused on how to advance basic science findings to the clinic. So you can see a list of names here, but there are many, many other types of cells that have been tested. So it's very hard to bring basic lab discovery, in particular when it comes to stem cells, because it is extremely difficult, which I'll show a little bit later. So if you look at the timeline, in 1992, that was the first paper which showed the harvest of satellite cells from dogs, and those cells were expanded in culture and implanted in the dog hearts after a cryo injury. Cryo injury is not the best model to test if the cells would work in patients with heart attacks. However, that's what was done. In about 10 years, in 2002, Bodo Strauer from Germany, he tested these cells from the patients with acute myocardial infarction. You may know there are two main types of heart problems for which stem cell therapy is being tested. One is called acute myocardial infarction. When a heart artery is blocked, then the patient gets a heart attack, chest pain and all that. And when that heart attack patient, after a few months or years, the heart begins to fail. So a failure, that's called ischemic heart failure, and then there are non-ischemic heart failure. So treatment of myocardial infarction and heart failure are different. So very quickly in 2003, Dr. Perrin from Texas Heart, he tested these cells in patients with ischemic heart failure. And that was followed by multiple studies. In 2004, there was the first randomized controlled trials with mesenchymal stem cells. In 2009, allogeneic cells were tested. And allogeneic cells are different from autologous cells. Autologous cells come from the same patient. Allogeneic cells come from other patients or normal humans. There are differences, but to use allogeneic cells is more advantageous because then you can keep the product, which is called off-the-shelf treatment. So the patient comes with heart attack, you already have the product, and you infuse that. But if you are going to use autologous cells, then those cells need to be harvested from the same patient, expanded, so it is more complicated and less feasible. So allogeneic cells were successful, and that was in 2009. Very quickly in 2010, a mesenchymal stem cell product was approved in Korea for treatment of acute myocardial infarction. 2011, we saw the trial from cardiac stem cells from Dr. Boli from Louisville. And then Stempucel was tentatively approved in 2016 in India. And people in the audience may know more about this because this was in India, and it was a major advance for critical limb ischemia. In 22, there was a first patch implantation with iPSC-derived cells. These are induced pluripotent stem cells. And 2023, we had a large trial which enrolled 537 patients, and I'll show the results a little bit later. And then 2024, the exosomes were tested in humans. So how effective is cell therapy? So this question has plagued the field since its inception. And for this particular field, for some reason, everybody is interested in the mechanism, not the outcome. So in 2007, 20 years ago, we did a meta-analysis which showed out of 999 patients from 18 trials, the ejection fraction, which is the number that we use, which means when the heart pumps every time in systole, that's the fraction of blood that goes out from the left ventricle. And that's a measure which is tied to mortality, so we look at that. And there are other numbers that improved as well, which are cardiac parameters. So in 20 years, the field has not improved as expected. There are many reasons for that. The primary ones are the cells are not retained in the heart very effectively. That's a big reason. If you inject 1 million cells, only 1% or less will be retained in the heart. The treatment effects, at least by numbers, are 2, 3, 4%. And people may argue that this is not very effective treatment. There could be tumors as well, which is rare. And clinical trials, to enroll one patient in a clinical trial, it costs about $50,000. So to do the trials with large number of patients with a p-value of less than 0.05, it takes a huge number of patients, and many companies are even unable to continue with their trials or quit. So that's another reason. But on the other hand, equally important are the undue expectations. Sometimes patients and investigators expect 10, 20, 30% improvement, which is not possible. Even when you look at the very successful drugs like Entresto, which is a combination of sacubitril and valsartan, even that product only improved survival by about 4%. So it is not fair to expect that stem cells will produce a huge benefit for the patients. And there are differences in opinions, and then the regulations are not very clear, even from FDA. If you call the FDA cell therapy, you may get different answers different times. So there are many challenges because it is not a straightforward option. It's not like you're giving aspirin and that's causing such and such effects. So there are variabilities in the donor. So it depends on who the cell is coming from. If it is the patient himself or herself, what kind of cell it is. Then of course the manufacturing variables are very complex, and that actually cells change. If you plate mesenchymal stem cells in culture, the phenotypes will change as the culture evolves. So typically in the basic laboratory, we use cells from passage 2 to 5 because that's when we have a stable phenotype, so we can have reproducible results. So it's very important to optimize the cell manufacturing parameters. Then it depends on how you're giving the cell. If you're giving it intravenously, you're giving it through the endocardial route, and that can impact the outcomes tremendously. And finally, the recipients. Not everybody is we know that we talk about personalized medicine. That is probably very important for stem cell treatment because depending on the recipient, outcomes may be different. So the outcomes of cell therapy in the last 25 years have been highly variable. That's one big reason why translation to the clinic has not been very successful. Now this summarizes the different approaches or types of cells that have been used. So something we call first generation cell therapy used more simple cells like bone marrow mononuclear cells, mesenchymal stem cells. Then came the more sophisticated cells such as iPSCs, cardiac stem cells. Then those were changed out because it was realized that injecting the cellular DNA is not really important or necessary. So if you use the secretome or the link RNAs or miRNAs from stem cells, that could in itself produce the benefits. And then more newer studies are using a combination of biomaterials such as hydrogels and cardiac patches and putting cells in them That way, cellular retention is better. And hopefully, the results will improve with these newer approaches. Now, I will go over 2 or 3 trials that are newer. So, this was the big trial that enrolled 565 patients with mesenchymal precursor cells, and 537 patient data were analyzed. And this was a double-blind, randomized controlled trial. Cells were injected transendocardially, and placebo patients received standard of care, and the subject study patients received the mesenchymal precursor cells. These are STRO1 positive cells that were described in early 2000s. So for this cell type to come to reasonable clinical use and trial, it took 20 plus years. So what's more important, they published the recent data. Here we show on the left top, this shows if patients, control patients with higher hsCRP, more than 2, and this is less than 2, there is a difference. The patients with high hsCRP has significantly worse clinical outcome. And when you compare high hsCRP patients, control and treated with cells, there is a significant benefit. That difference is similar when you look at patients with high IL-6. Interleukin-6 is a marker of inflammation. And so what these graphs show, that even if you are in the control group and you have high interleukin-6 or CRP at baseline, then your outcomes are going to be worse. And if you treat with cells intramyocardially, then the benefits are more pronounced in patients who have greater inflammation in the background. This is true for outcomes as well. This is myocardial infarction and stroke during 5-year follow-up. And as you can see here, patients with higher inflammation at background and cell-treated patients benefit definitely in a high ischemic patients in a high inflammation setting. And that is, the same is true here as well. The reduction is 40 to 60% in the outcome analysis. This is another trial which is using a different type of cell. So this is cardiac heart failure. And here the patients are selected at baseline. So that is done by, this is a double-blind randomized control, total of 200 million autologous cells. So they do a potency assay at the beginning. So the patient comes before the cells are injected, the bone marrow is harvested, and cells are checked. Patient cells are checked for some markers. And if they qualify, only then that patient is enrolled. So the qualification depends on if they have a high CD34 positive cell in their bone marrow. And they have published data from 10 patients, and there was improvement in 6-minute walk distance, and also they had an improvement of New York Heart Association class at 24 months. So these are important outcome parameters for these cell therapy treatment for heart patients. So they are now doing a trial where they are looking at the benefits of bone marrow derived cells in chronic myocardial ischemia. Patients with a high angina burden will be enrolled, and this trial is actually recruiting patients at this time. There are other types of trials that are going on in which umbilical cord derived mesenchymal stem cells are being used. So umbilical cord, human umbilical cord has supporting cells. Mesenchymal stem cells are present in all the organs. These are supporting cells. They are in the perivascular tissue, they are in the bone marrow, they are in most organs. So the ones that are in the umbilical cord, we have also found in our results that they are more immune modulatory in nature. So they can suppress inflammation. So these cells are being used in this trial which is giving it intravenously. So to give a cell therapy through the heart is much more difficult and complex. So these trials hopefully will have benefit to show with an easier route of delivery. This is a trial in which highly purified ventricular muscle cells are being used as a spheroid. They are developed in the culture as a spheroid, and then they are going to enroll 10 patients. These trials are still ongoing. So they are enrolling 5 patients with a lower dose of 50 million, and another 5 patients will be enrolled in the 150 million cell group. So their safety data have shown that 50 million cells were tolerated well by the patients. So the next stage is going on with 150 million cells. This is yet another type of approach in which a cardiomyocyte patch is developed from induced pluripotent cell-derived cardiomyocytes. These patches are developed in vitro. These are about 3.5 centimeter patches, and they are sutured onto the myocardium. So they open, when the chest is open, the myocardium is exposed, pericardium is cut, and the patch is sutured there with proline suture, which is absorbable. And so the patch stays there so that it's not displaced, and the images in the lower panel are showing the red area means vascularity, basically. And so that has improved at 1-year term in patients who received these types of patches. So there was improvement in cellular myocardial contractility as well. So another type of approach involves the use of secretomes. So some of you may know these are called exosomes or extracellular vesicles. There are a lot of data in the basic animal models in which the use of secretome improves the different cardiac parameters and whatnot. So there is a trial going on. This is the first of its kind in Europe, and where these secretome or the exosomes are being injected intravenously. Patients are getting these injected 3 times, 3 weeks apart. And the first patient has showed promising results insofar as this was tolerated well, and there was some improvement in heart function and New York heart classification. There are a number of studies that are currently going on with advanced technologies and products. These include induced pluripotent stem cell, patches, exosomes. These data are from clinicaltrials.gov, and some of these studies are happening in Asia as well as in the Americas. So what's the outcome that we are most interested in? So of course, you want the patient to live longer. I think that's the most important outcome. So we did another meta-analysis in 13 years ago, and we showed that cell therapy improves survival. So this has been confirmed. I don't update this slide, but in a number of meta-analyses, it has been shown that if you give cells to a patient with heart disease, cell therapy, the survival is improved by 30 to 70%. We do not know the reason, and there are many labs that are working on that. However, the fact remains that cell therapy improves survival. So we did a smaller meta-analysis recently in mesenchymal stem cell area, and
So you will have to sum up soon.
Sure.
Yeah.
We have, we'll go over this very quickly. It takes a long time, 12 to 15 years. Like I said, the trials that are going on now, those cells were described 20 years ago. So the trial that we are doing in GVHD, I won't go over that, but that also we started in 2013, so it's 12 years. So these are the products that have been approved in different countries. That was the first one. This is in India, and also this was first approved in US. After all these years, this was approved in 2024, and that was for allogeneic bone marrow mesenchymal stem cells. So in conclusion, we can say safely that cell therapy modestly improves heart structure and function in patients with ischemic heart disease. It also improves survival. Newer approaches, like I showed a few examples, may improve these outcome benefits further. And many different products, I did not show the full list, there are probably about 12 products, cell therapy products that have been approved in different countries for various indications. I'm indebted to these individuals who our lab collaborates with, and they also generated our data that I showed. This is our school. Thank you for your attention.
Thank you, Dr. Buddhadeb Don, for the insightful insights on, the development of adult stem cells in cardiac conditions. So we have time for one question.
It's a beautiful presentation, Dr. Don, and
Thank you.
it really tells about the future of the mesenchymal stem cell therapy. And if you do the intra-arterial injection of these cells, how many of them reach to the site of the injury, and how do they attach over there?
Great question. So intra-arterial, you probably mean intracardiac.
No, I'm sorry,
Intravenous. Okay. So if you inject any kind of biological material intravenously, most of that gets filtered out in the liver and in the lungs and also in the spleen. So eventually there have been pig studies from 2005 or so in which they showed the actual number of cells that reach the myocardium varies anywhere between 1% to 9% at the most. So we think that the benefits are not coming from the cells that are going to the target organ. The benefits are coming from the secretome that are also in the blood.
So accordingly, the effect of exosomes probably will be more effective than the use of the mesenchymal stem cells.
Yeah, that's what the field is expecting, because now we have hundreds of preclinical studies that have shown that all the contents I showed in a slide briefly, it includes about 850 microRNAs. It includes different nucleic acids and whatnot, receptors. So they are the real effectors of cell therapy. And so if you give them directly, the benefits will be more pronounced, and there will be no side effect that may come from the cellular DNA.
Thank you, sir. I think the off-target migration of the adult stem cells can be a major issue in therapeutic scenarios. So probably the secretomes would be a better, this with lesser risk associated with it. In the future, probably those studies would be more robust and might lead to more clinical success.
Yes, thank you. Off-target effects of cell therapy are not much, though. There are very few adverse effects that have been reported. There was one case report of intracardiac calcification with mesenchymal stem cells, but I am not aware of too many off-target cardiac cell therapy side effects. However, the point remains that if we inject the concentrate that has all the goodies, that may do the job much better. Yes.
Thank you, Dr. Don. Thank you.